And a warm welcome back to WoundCasters by Wound Care today, where we explore the gaps by exploring the truth. I am your host, Felix Boecker, and I will be taking you on another wonderful journey through the world of wound care. Today, we're diving into a topic that's foundational to modern wound care, but also highlights how much our understanding and practice have evolved. Wet to dry wound dressings. Now, for many years, a common approach involved something called wet to dry dressings. But as wound healing science has progressed, this method has increasingly come under scrutiny. Today, let's explore the history of wound dressings, the pivotal shift towards moist wound healing, and why wet to dry dressings should only be relegated to the history books. Now, picture this for a moment: the dawn of medicine as a specialty. In our caveman days, we did not know about diabetes or heart disease, high blood pressure, or cancer or strokes. No, where medicine really began tens of thousands of years ago is with wounds. Wounds we sustained while hunting and gathering for our foods and protecting our tribes. And yet, after all these years, and despite all our modern advances, wound care really seems to be stuck in the Stone Age. In Egyptian times, the management of wounds involved materials like grease-soaked gauze bandages. The primary goal then, as it remains today, was healing. Over the centuries, wound care became a little more sophisticated, but traditional dressings like gauze stuck around. They are non-occlusive, meaning they don't create a sealed environment, and they tend to dry out. When traditional dressings like gauze dry out, they adhere to the wound bed. This can cause wound trauma and pain to the patient upon removal, sometimes resulting in bleeding because capillary loops, which are part of the granulation tissue, can grow into the gauze dressing itself. This traditional approach focused on keeping the wounds dry, based on the belief that this is what promotes epithelialization. The real revolution in wound care science, particularly concerning dressings, began in the 1960s. A pivotal finding demonstrated that wounds kept in a moist environment heal 2 to 3 times faster than those allowed to dry out. These initial findings were based on observations where a plastic cover created this beneficial moist environment. Further studies in humans went on to confirm these findings, showing not only faster healing, but also better tissue quality with less scarring and reduced pain. So, this concept then, that keeping a wound moist is beneficial, is clearly not new. It's been around for decades. And based on these findings, dressing manufacturers began an evolutionary development process, providing a comprehensive range of dressings designed to work on the principle of creating a moist environment. This environment aids healing, minimizes or eliminates wound pain by soothing nerve endings, and allows healing to progress more naturally. Now, none of this should have ever come as a surprise. We are a water-based organism. We're mostly water, and our chemistry happens in water. No water, no chemistry. No moisture, no healing. The widespread introduction of moist wound healing truly took a new direction in the 1980s. The modern wound care revolution escalated in the late 80s and early 90s with a significant increase in new products and intense scientific and clinical research around moist healing. We now routinely accept that moist wound healing is superior to dry dressings for wound management, based not only on healing speed, but also on patient and wound-related factors. So, where do wet to dry dressings fit into this picture? Despite the overwhelming evidence supporting moist wound healing, wet to dry dressings continue to be commonly used even today. I see this most commonly used as a backup dressing with negative pressure therapy, for example, but I have seen quite a number of patients who still use some form of wet to dry dressings every day when seen in wound clinics by wound care specialists. I think this is often a result of tradition rather than evidence based practice, highlighting a major gap between research and practice. There is a significant knowledge deficit among all healthcare professionals regarding the use of wet to dry dressings versus other modern dressings that are readily available and provide superior outcomes. A key issue is that wet to dry dressings, by their very nature, do not maintain a continuously moist environment. They are primarily indicated for mechanical debridement. Mechanical debridement using wet to dry gauze involves physically removing wound tissues. However, this is a non selective form of debridement, meaning it removes not only necrotic tissue, but also healthy, granulating tissue. Using wet to dry dressings comes with several disadvantages. Pain and trauma. When the gauze dries and adheres to the wound bed, its removal is painful for the patient because it can pull away healthy tissue and expose sensitive nerve fibers. It causes delayed healing because they impede healing by removing migrating epithelium and causing local tissue cooling. Research from the 60s showed that dry wounds heal 2 to 3 times slower than moist wounds. There's an increased infection risk with wet to dry dressings. Gauze dressings, particularly moist ones, have limited ability to provide a physical barrier to bacteria. An in vitro study showed bacteria could penetrate up to 64 layers of dry gauze, and moist gauze provides an even weaker barrier. Infection rates for wounds treated with moisture-retentive dressings were significantly lower compared to gauze-based dressings. 2.6% versus 7.1%. It's an almost fourfold difference. Wet to dry dressings are labor intensive. They require frequent changes, making them labor intensive for healthcare providers, especially the nurses doing the dressing changes. These dressings really need to be changed multiple times a day in order to maintain some type of moisture content. There's a lack of cost effectiveness. While the initial unit cost of gauze may seem lower, the overall cost effectiveness is poor when considering provider time, increased frequency of dressing changes, and longer healing times. Advanced dressings, although initially more expensive per unit, can be less costly overall due to less frequent changes and faster healing. And wet to dry dressings are often prescribed inappropriately, even when mechanical debridement is not clinically indicated. Several clinical guidelines and regulations now discourage the use of wet to dry dressings. The Association of Advancement for Wound Care guideline explicitly states that mechanical debridement using wet to dry gauze is considered substandard practice. And the Institute for Clinical Systems Improvement guideline notes that wet to dry dressings are not continuously moist and therefore not recommended. A blunt and powerful quote underscores this issue. There is ample evidence on how to give wounds the opportunity to heal by providing a moist physiological environment for the cells that do the work of healing. Yet practitioners thoughtlessly expose wounded tissues to desert environments that desiccate and kill healing cells. This dried tissue, often with gauze remnants acting as foreign bodies, is more prone to infection and pain and heals more slowly than if it were kept physiologically moist. The limitations of early moist dressings like film dressings, which sometimes cause trauma upon removal despite providing pain relief by keeping the wound surface moist, led to the development of much better products. Today, clinicians have access to a plethora of advanced wound care products designed to maintain a moist environment while addressing other wound needs. Hydrocolloids, for example. These gel with wound fluid, creating a moist environment, and studies showed they produce less pain than gauze. There are foams, which offer absorption and often an easy to remove, non adhesive contact surface, and studies showed fewer infections with foam compared to gauze. Alginates, they are transforming from fiber to gel upon contact with wound fluid, providing a non-stick surface and also a moist environment. Of course, there are hydrogels, providing high water content in a gel, making them non-adhering, soothing, and providing the necessary moisture. These products aim for a moisture balance, managing exudate while preventing the wound bed from drying out and surrounding skin from becoming macerated. They're designed to be non-stick for optimal pain control. And beyond these traditional advanced categories, technological advancements have led to biologically active dressings incorporating collagen, hyaluronic acid, peptides, and growth factors, as well as novel approaches like the use of negative pressure wound therapy. Studies consistently show that advanced wound care dressings lead to improved outcomes compared to wet to dry dressings across various factors, including healing time, pain, infection rates, and costs. There is strong evidence supporting the use of moist wound healing and none to support the ongoing use of wet to dry dressings. Now, you might ask, what about using hypochlorous acid or sodium hypochlorite instead of saline wet to dry dressings? First of all, both of these products are cleansers, not soakers. The half-life of a sodium hypochlorite solution is only about 15 minutes, which is why sodium hypochlorite, more commonly known as Dakin's solution, was initially designed as a continuous infusion. So you would have to change the packing about every hour in order to maintain efficacy. Clearly, that is not feasible. As for hypochlorous acid, the half-life can be as long as 48 hours, so it would be a much better choice for wet to dry dressings. However, this product again is designed as a wound cleanser. It can also dry out over those 48 hours, again leading to tissue trauma upon removal of the packing. The only studies that have ever been done that sort of relate to the use of hypochlorous acid soaked packing are installation negative pressure therapy studies. I have not been able to find any studies that looked at using it as a soaking agent with gauze and wounds. If you know any studies, please send them my way. So, in summary, the history of wound dressing shows a clear evolution from basic, often painful, and ineffective methods towards sophisticated materials designed to optimize the body's natural healing processes. While wet to dry dressings served a purpose for mechanical debridement, the evidence is now clear that they are suboptimal for promoting overall wound healing. They fail to provide continuous moisture, cause pain and trauma, increase infection risk, and are not cost-effective in the long run. Evidence-based practice strongly supports the use of advanced, moisture-retentive dressings that create the optimal healing environment first described over 50 years ago. Transitioning away from the outdated tradition of routine wet to dry dressings towards modern, evidence-based strategies is crucial for improving patient outcomes and promoting fiscal responsibility in healthcare. Wound care specialists like you are in a key position to advocate for the use of these more effective products. And with that, I want to thank you for tuning in to WoundCasters by Wound Care today. If you like this episode and want to hear more, do me a quick favor and like this content in your favorite podcasting app. Be sure to subscribe so you don't miss out on future episodes. While we're only getting started, we have a lot of amazing conversations in the pipeline. So join us again next time as we explore yet another vital aspect of wound management. Ciao.